Sorry about that. Hi, good morning and welcome to the Bipartisan Policy Center's webinar on advancing primary care in the Medicaid program. I'm Catherine Hayes, BPC's Health Policy Director. Evidence shows that when done well, primary care can help expand, it can help individuals live longer and delay or avoid costly chronic conditions such as cancer, diabetes, and heart disease. Today, BPC is releasing a report, Advancing Comprehensive Primary Care in the Medicaid Program. This is the product of a year of research and work including input from a broad variety of stakeholders. We will discuss the barriers. The report discusses the barriers and makes recommendations to Congress and the administration. Comprehensive primary care is notable because of the use of care teams, which include physicians, nurses, pharmacists, social workers, and other health professionals. Typically, electronic transmission of information between providers is very important, and also the reporting of quality measures. While the majority of Medicaid beneficiaries under the age of 65 receive their care through Medicaid managed care, these principles of comprehensive primary care can, but often do not, carry over into managed care organizations. Before we get to the panel discussion, I'd like to recognize our funders for this project, Lori Zephyrin, Vice President of Healthcare Delivery System Reform with the Commonwealth Fund. Lori?
Great. Good morning. Thank you, Catherine. And thank you all for being here. A big thank you to the BPC team, and particularly to you, Catherine, and to Eleni for your leadership in the analysis and commitment to engaging various viewpoints in this work. The Commonwealth Fund, as many of you know, is a national foundation, and we're celebrating our 101st year. And we're committed to promoting a high-performing healthcare system, one that achieves better access, improved quality, and greater equity. And high quality, comprehensive primary healthcare is a fundamental building block of any healthcare system. There's longstanding evidence that primary care can improve outcomes, increase equity, and lower per capita costs. And Medicaid is truly a critical lever in ensuring access and comprehensive healthcare to low income and people vulnerable to inequity. As all of you know, a signature of Medicaid is federal and state partnership. And often when we're doing analyses and looking at Medicaid, we highlight all of the innovation at the state level, and whether it's behavioral health integration, integrating social needs, or expanding the use of community health workers and many others, these state level innovations and transformations are important. And this time around, however, what we wanted to do was partner with the BPC to really examine the critical barriers and opportunities that exist in federal Medicaid policy to advance primary health care, and really to explore which of those federal policy levers can be pulled to help all states better meet the needs of those on Medicaid. We're living in the midst of a pandemic, one that's exposing longstanding inequities in all aspects of our society, including healthcare, in healthcare. And one intervention that can work to advance health equity is a strong foundation of comprehensive primary health care. This report lays out a number of strong recommendations that can address some of these inequities and prepare us for the next crisis and help us get through this economic downturn. An important contribution of this report is the call for a national comprehensive framework for improving primary health care, as well as calling our attention to what we are spending on primary health care. The report outlines a number of important recommendations, many of which could begin to address long-standing racial and ethnic inequities. Thank you for participating. I really look forward to this conversation today and partnering with all of you on how to strengthen primary health care and to improve quality and advance equity. Thank you.
Thank you, Lori. I'd like to now turn to Lisa Harutunian, who is a senior policy analyst here at the Bipartisan Policy Center, to provide a brief overview of the barriers and the recommendations, and then we'll move on to the panel.
Thank you so much, Catherine. Today, I'll provide an overview of the report that the BPC is releasing today to advance the comprehensive primary care in Medicaid. I'll briefly describe how the BPC defines comprehensive primary care, the 4 overarching goals of our federal policy recommendations to advance the delivery of comprehensive primary care, the key barriers to achieving those goals, and finally, the BPC's policy recommendations that aim to meaningfully address those barriers. In this report, we discuss the success of the patient-centered medical home model and the Medicaid health homes model for individuals with chronic conditions. These patient-centered models highlight the advantages of a comprehensive approach to primary care, and they have informed the BPC's definition of comprehensive primary care. In working with stakeholders, while stakeholders did not completely agree on a definition of comprehensive primary care, there was a willingness to identify common elements and a recognition that core services may differ depending on the population at hand. So stakeholders acknowledge and the evidence in the patient-centered medical home model and the Medicaid health homes model all suggest that certain attributes contribute to support the comprehensive primary care in Medicaid, but these should be aspirational rather than mandatory attributes. For the purposes of our discussion, key elements of comprehensive primary care would include multidisciplinary teams that are diverse and include a full range of health professionals, including community health workers who have the ability to identify and coordinate both health and social services, an integrated or at least coordinated delivery system that includes clinical health services, behavioral health services, and social services and support. The ability to access these services outside the traditional medical office or clinic setting, engaging the patient and the family to identify patient needs and preferences, addressing equity and eliminating disparities, delivering adequate payment with mechanisms for sustainable financing that reward high value, identifying and financing services that have the ability to improve the social determinants of health, and using real-time data and establishing continuity with patients through all stages of their life and care. So now that I've described what we mean by comprehensive primary care, I'll describe how we seek to advance the delivery of comprehensive primary care in Medicaid. The BPC's policy recommendations aim to achieve 4 main goals. First, to support a comprehensive framework for improving primary care. Second, to improve access to insurance coverage and healthcare services. Third, to strengthen the Medicaid primary care workforce. And fourth, to address racial, ethnic, and economic disparities in Medicaid. In developing policy solutions directed at our first goal of supporting a comprehensive framework for improving primary care, we identified challenges that included a misalignment of payment and delivery models and a lack of time and resources at the provider level for implementation of innovative programs. In an effort to address these challenges, the BPC is making several recommendations. We recommend that Congress elevate primary care as a priority for Medicaid by directing the Secretary of HHS to work with existing learning collaboratives and researchers to support the sharing of best practices among states. These primary care focused learning collaboratives would help states share best practices on topics ranging from addressing the social determinants of health to reducing health disparities, expanding the use of telehealth and Medicaid, and transitioning from volume-based fee-for-service payments to value-based payment approaches that support innovation. We also recommend promoting the measurement and reporting of primary care spending as a percentage of total healthcare spending and appropriating funding for the primary care extension program, which was originally authorized under the ACA, but funds were never appropriated. Regarding our second goal, to improve access to insurance coverage and healthcare services, we identified barriers around a lack of access to affordable coverage and services, a lack of coverage or underinsurance of some individuals who are eligible but not enrolled, gaps in coverage leading to disruptions in care, and the affordability of care. To improve access to affordable health insurance coverage, the BPC recommends that Congress permit non-expansion states to expand Medicaid coverage under one of two options. The first option would allow states to adopt a traditional Medicaid expansion approach. For those with incomes up to 138% of the federal poverty level, and the state would receive 100% federal match that is phased down to 90% over 5 years. The second option would allow states that have never expanded Medicaid to expand coverage to those with incomes up to 100% of the federal poverty level, with a lower 88% federal match, provided that the state expands coverage within 2 years of enactment. Also, to support the enrollment of eligible individuals, we recommend that Congress permit states to auto-enroll those eligible for coverage in Medicaid, CHIP, or the marketplace subsidies into the appropriate programs. For the marketplace auto-enrollment, that would only apply if the individual subsidy met or exceeded the marketplace premium cost. To reduce gaps in coverage and disruptions in care, we recommend that Congress create a new state option for 12 months of continuous Medicaid eligibility for adults. And to ensure preventive services are affordable and accessible, we're recommending that Congress require the coverage of preventive services for adults in the traditional Medicaid population without cost sharing. For our third goal, strengthening the Medicaid primary care workforce, low provider reimbursement rates, the lack of data-driven network adequacy requirements in managed care, and the limited capacity of the primary care workforce all created barriers to meeting workforce needs. To ensure that reimbursement for primary care providers is sufficient to support access to primary care, the BPC recommends increasing federal match to states to 100% for primary care services, including primary care services delivered through telehealth, for states that reimburse at Medicare rates for 5 years. To strengthen Medicaid network adequacy requirements, we recommend delaying proposed changes to the managed care network adequacy requirements, and recommend that the Medicaid and CHIP Payment and Access Commission develop data-driven access standards that take into account impacts on the medically underserved populations, including those in rural areas. The Secretary would then promulgate regulations based on the new data-driven standard. To increase primary care workforce capacity by addressing health professional shortages, we recommend that Congress direct the Secretary to establish a comprehensive plan to ensure the oversight and coordination of all the federal programs that address healthcare workforce needs. Also, to reauthorize the Conrad 30 program and expand the number of J-1 visas each state receives through the program from 30 to 50, with priority given to those in rural areas. We also recommend that during a public health emergency, restrictions should be revised for international medical graduates on H-1B visas to support the transfer from an assigned site of service to another within the health system, such as a transfer to work at an overwhelmed hospital or facilities with staff shortages, and to permit these individuals to provide telehealth services in areas of need as well. And lastly, in this section, to reauthorize federal funding to the Community Health Center Fund at the current level of $5.6 billion annually, as stable long-term funding is needed to ensure continued access to care for the vulnerable populations they serve. And finally, regarding our fourth goal, targeting racial, ethnic, and economic disparities in Medicaid. While Medicaid plays a critical role in serving individuals with disproportionately lower incomes, including racial and ethnic minority groups, the elderly, individuals with disabilities, those with limited English proficiency, complex conditions, or disparate access to care, such as rural populations. To prevent discrimination and to encourage states to address disparities in Medicaid, we're recommending that Congress block implementation of the June 2020 final rule, which eliminates non-discrimination provisions and directs the GAO to determine the impact of that rule. If the GAO determines that access to care would likely be harmed under the rule, then we recommend Congress block implementation of that rule. Also, to prevent discrimination and address disparities, we recommend that Congress direct the Secretary to provide guidance to states on defining and reimbursing for community health workers where evidence has demonstrated improved outcomes for those with chronic conditions. To increase accountability for ensuring non-discrimination and access to Medicaid benefits for individuals with disabilities, we're recommending that Congress direct the Secretary to require that states establish monitoring and enforcement mechanisms that ensure Medicaid and CHIP providers are complying with laws prohibiting discrimination against individuals with disabilities. And lastly, to improve the financing and coverage of proven cost-effective interventions that address social needs for high-risk populations, we recommend that Congress provide the Secretary with the authority to approve Medicaid coverage of non-medical services that address social needs, if the Secretary certifies that certain conditions are met. In summary, a strong case can be made for investing in and promoting a more comprehensive approach to primary care. Federal policy limits the spread and scale of comprehensive primary care, and strong leadership at both the state and the federal level are needed to address these barriers. While significant progress in improving primary care in Medicaid has been made, we hope that these recommendations can provide a roadmap for next steps. We believe these recommendations are a meaningful step in the right direction, but more can and should be done to identify barriers and promote primary care across programs and payers. Thank you. I will now turn it back over to Catherine Hayes.
Thank you very much, Lisa. We appreciate that. I'd now like to turn to our panel to discuss both the challenges that are being faced by states in delivering primary care, but also to talk about the implications of COVID-19 on primary care and Medicaid. I'd like to introduce Sheila Burke, who is moderating the panel today. Sheila is one of BPC's Future of Health leaders and is a senior advisor to BPC. Okay, Sheila.
Great. Thank you, Catherine. And thank you both for the summary that we've been provided, as well as the extraordinary support that Commonwealth has provided to us over the course of the last few months as the work really continued on this project. Lori has been a wonderful partner in helping us both in a roundtable discussions that have been held, as well as in helping us identify the issues, as well as resources that we might draw upon in terms of examining these very important questions. As has been pointed out by both Lisa, as well as Lori, and by Catherine, this is not a new issue. These are not new questions that are being asked in terms of the importance of primary care, but it has a heightened sense of importance given the unique set of circumstances we're confronting as a result of the virus, as well as the challenges that the states are facing in terms of providing these services. And it clearly has underscored the importance of a strong primary care system as really a part of a high-performing healthcare system. Over the long term, that is in fact our goal and what we hope to achieve. In our discussions this morning, I want to give you just a little bit of a layout. One, I'm going to ask each of our three panelists to speak for just a couple of moments about what they believe to be the most important messages that have resulted from the study, to highlight those things they think are most critical for us to examine. I'm then going to engage them in a conversation, ask them some questions about their unique experiences. And then finally, we will open it up for discussion. And I encourage all of you to submit your questions through the Zoom process so that in fact, folks can have the opportunity for hearing from you and answering the things about which you are most concerned. So let me first, before we turn to each of the speakers individually, introduce them briefly. Many of you will have come in contact with them before and realize really the benefit of having their comments and impressions around these questions. I'll begin with Haimi Tourson, who many of you know, who is the Division Director of Health at the National Governors Association. She, again, has been a critical element to our discussions, helping to provide us a great deal of information about what's taking place in the states, and has a unique opportunity to really focus on what, in fact, the states are doing and what kind of challenges they're facing. Prior to joining the NGA, she had decades of experience in health policy in both the public and private sectors, and served as a senior attorney for the Office of General Counsel at the Government Accountability Office. So again, she's looked at it really from a variety of sides that I think will be quite helpful. I'll then turn to Ben Schaefer. Ben is the Medicaid director for the state of Rhode Island. Again, a long history in Rhode Island and both their Office of Management and Budget, as well as now the state Medicaid director. And Ben, we're going to count on to really reflect on what the states are confronting, what unique challenges, and also the opportunities that they've taken advantage of, particularly in the context of waivers and the authorities that are being made available to them. And then finally, our third panelist is a relatively new entrant into the healthcare system, but on the lines, and I think can help reflect on the unique challenges that providers are facing. Kelly Tibbert is a resident member of the board of directors of the American Academy of Family Physicians. She is a recent completion of her residency and is now essentially actively engaged in the Ohio Health Grant Medical Center in Columbus, Ohio, and is looking at this and helping us look at it both from the professional standpoint of the association as well as her unique experience on the lines in terms of caring for patients and the kinds of challenges that she sees and opportunities in providing primary care in a local setting. So I'm going to turn first to Hammy and ask her to give us just a couple of moments. I'll then ask Ben to give us a couple of thoughts as well, and then finally turn to Kelly, and then we'll open it up for our internal discussion, then open it up for questions from each of you. So Hammy, over to you.
Can you hear me? Yes, great. Okay. Well, thank you for that introduction, Sheila. And I'm so pleased to be on this panel with Ben and Kelly today. And kudos to the Bipartisan Policy Center for really focusing work on primary care. It is a critical topic in the midst of many critical topics. And I appreciated the depth and the insights that this report provides. So thank you for doing that. And I'm honored to be part of this panel. One of the things I just wanted to mention, for those of you who are not familiar with the National Governors Association, we represent all governors, so Democrats and Republicans alike. And we are really focused on what are the governor's priorities and how can we serve them. Within the Governors Association, there are two parts, the Center for Best Practices and the Office of Government Relations. And I sit in Center for Best Practices side. And I say that because we really focus our work on how do we work with governors and their teams to move policy forward by providing examples from other states, insights from experts, learnings on what states have done before and has worked or has not worked, and really work closely with them in that capacity. And what I'm going to talk about today really comes from that work. Really working closely with states over many years on delivery system, payment reform, thinking about access. So hopefully those comments are helpful. One of the things that we were all thinking about before COVID happened was, investments in the healthcare system and where is that needed to really improve outcomes while reducing costs. It was a hot topic back in for the last year or two or three, however you want to count. And it continued to be in the beginning of 2020 of states really trying to identify how do we really do better with our healthcare systems? And a piece of that is how do you invest in primary care? How do you make the longer term infrastructure investments to have folks be able to get the care that they need earlier rather than when they get sicker and they have to go to the hospital? I think we all know that, and that is one of the fundamental principles of why we're all here in the work that we do. Before COVID-19, I would say, where we saw some real interest at the governor's level and, their teams was in behavioral health integration. That was one piece where a lot of states were moving towards thinking about and how primary care fits into that. The second piece was how do we really understand cost? And how do we think about making better investments to reduce the overall cost growth in our states of our Medicaid program, but also at large, where you have on the commercial side, on the exchange side, premiums going up because healthcare costs are going up. And so that was a question that we were really spending a lot of time working on. And I was pleased to be part of the primary care panel back then here at BPC, and I'm happy to be back again. So what I want to talk just a little bit today about what has happened in the midst of COVID-19 and have those priorities change, and how does this report help us continue to focus on that issue? From where I sit, we have been working with governors and their staff 24/7 on COVID-19 response, because that's what everybody has had to do. This is unprecedented, both from a public health perspective, but also from an economic perspective. The governors in particular have been very concerned about, the shortfalls in their budgets, how to sustain operations in their states with those cuts, and how to frankly continue to make progress on things that we know are important in the midst of less resources. All the while trying to really get control over a pandemic that is right now not under control. So that is a really complicated set of challenges that we have been working on in different ways. And one of the things that I appreciate about this report and reflected on as I read it, where there's pieces in it about establishing collaboration and learning for states, having the federal government help set a path. And I think that is a critical point. I'm very glad Ben is here. Rhode Island has done some amazing work on primary care, and I know they continue to do that. There are other states like Oregon and Vermont and Arizona that have really, before COVID-19, really invested and made some changes. But these things don't happen overnight. I mean, these are longer term program changes. And my concern, just at a very global, not specific, talking about any particular state, but at a global level, looking across the states, is there is just less resources. State staff have to focus on COVID-19. There are fewer of them. And because of that, it's really hard to have the state capacity to focus on launching a big program if you haven't already done it. So, I really appreciate it in the report, focuses on how can, a path be set? How can these initiatives be supported through learning collaboratives, through, HHS taking some steps to put out best practices, to support states in how they can move forward on this. I think that's of critical importance at a time when there are so many different priorities. The last thing I'll say, and I know Kelly will probably comment on this, my concern is, what does our healthcare system look like after COVID? And where are there providers that are really challenged right now because there is lower utilization, because of the changes in the way we do business? Medicaid in particular, in some states, not all, have vulnerabilities in their networks. And how can those programs be sustained given the budget cuts that states are going to have to address, as well as sort of change in people's behavior because of the concerns around the virus? So all that to say, I'm really looking forward to the discussion, and I'll turn it back to Sheila for now.
Great.
Thank you.
Terrific. Thank you, Amy. We're definitely going to want to come back to a number of the issues you've raised, including what you might imagine the feds could best do, in fact, in supporting the states. But also the question you ask, and you're right, Kelly, I think, will be prepared to help us think about, and that is, what does the system look like post-COVID? What kinds of transitions in healthcare delivery, the role of things like telehealth, what kind of an impact does that have? How does that help the states address some of these issues? So thank you for that, and thank you for teeing up those questions. I'm going to turn it over to Ben to talk a little bit about Rhode Island and give us just a couple of opening comments on what he found in the report to be particularly helpful. Ben?
Sure. Thank you, Sheila, and thank you to the Bipartisan Policy Center and to the Commonwealth Fund for producing the report and for having me on this panel today. As Hemi mentioned, Rhode Island has a long history in primary care and supporting patients under medical homes, in particular, going all the way back to 2008, with continued add-ons and significant continued work in that area. So when I sort of read the report and saw a lot of that reflected, and saw still how we should improve and continue to think about advancing primary care, it was certainly heartening to see sort of some of what we've already been doing, and encouraging to see the things that we should do next. I'll be brief on to highlight a couple of the recommendations that particularly spoke to me in my current role as Medicaid director in Rhode Island, and Hemi touched on it, which is, we currently pre-COVID, but obviously post-COVID are maximally concerned with the budget, and have to be finding ways to balance budgets at the state level, And when Medicaid is a third of the spending, generally speaking, in state budgets, you have a primary responsibility to play there, but need to do that in such a way that doesn't jeopardize outcomes for beneficiaries and outcomes for patients. And supporting primary care in that is obviously critical. So with that in mind, the one recommendation that drew my sort of quickest attention was the recommendation to increase state FMAP to 100% for primary care services for states that increase rates to 100% of Medicare rates. This was obviously in place immediately following the ACA. It's what our primary care community continually asks for. And what's intriguing to me about it in particular is in overall healthcare spend, it's not very much money, but has that tremendous impact and that tremendous ROI. Second, and Lisa talked about this in her overview, but exploring the reimbursement of and getting clear guidance from CMS on reimbursement for community health workers and other non-medical services that are evidence-based really would be a game changer, I think, for state Medicaid agencies. We want to try and find ways to fund it, and we spent a lot of time thinking about it, as Sheila mentioned. But our hope is that we could make it easier and we could scale faster, and particularly scale faster with CMS guidance and CMS sort of work. And I think the fact that CMS has come out with different kind of checklist waivers, in particular to the public health emergency, could serve as a useful guide of the way in which we can cut down on some of the implementation timeline of some of these necessary initiatives. But certainly on the community health worker side, sustainability of funding and reimbursement match for that is something we talk about all the time, and in particular stresses the investment in community health workers from practices, from insurers when they don't know where that next dollar is coming from. And then last but certainly not least, and Lori mentioned this in her introduction, is to promote the spending measurement of spending on primary care. My colleagues at the Office of the Health Insurance Commissioner in Rhode Island have some of the leading regulations on this that require on the commercial side they spend at least 11% on medical care, on primary care. Having something similar in Medicaid or measuring across the country the amount of spend on primary care would help us really do more of those apples to apples comparisons and continue to show where we need to put our healthcare dollar to achieve better value. So I know we'll get into more details sort of than that, but wanted to make sure I highlighted from my perspective those three particularly cogent and I think important recommendations in this report.
Thanks very much, Ben. Again, you've given us a number of things to think about. One of them that I think is an interesting question for all of us to examine is this question of the percentage of spend on primary care. The questions around network adequacy have been a challenge in the context of the ACA and how one measures that and what the right measurements ought to be. The question of a spend on a particular element of services is an interesting question. One wonders what we already know and the extent to which we can benchmark and whether the obvious first step is to begin to understand what in fact is occurring and then figuring out what best practices might be. So we'll certainly want to come back to that and talk about that issue and the question of guidance from the department in terms of community health workers and what role they might play. And part of that is this question of what does healthcare look like over the long term, and particularly as we begin to look at social determinants of care and the influence that has in terms of people's health and well-being. So we'll certainly want to come back to both of those questions as we go forward. Kelly, let me turn it over to you for your sort of opening comments and your impressions of what was most critical in the report.
Thank you, Sheila. And thank you for having me here and having the American Academy of Family Physicians participate in this really timely and fabulous report. The American Academy of Family Physicians works to solidify family medicine as the cornerstone of healthcare in our country and the healthcare system. And our goal is to achieve optimal healthcare for everyone, as we do see that we'll touch on later, and that was addressed in the report, that healthcare at baseline does have significant and disproportionately cared for populations within our country. With that, this report was extremely timely in that it addresses what we've been dealing with for many years in primary care, which unfortunately has been rather highlighted by the pandemic of COVID-19. And that is that access to primary care will ultimately improve the health of patients and decrease the costly interventions, and hopefully decrease necessary or unnecessary admissions to hospitals, while helping to reduce health disparities and addressing social determinants of health. In the past, we've seen family medicine has continued to address social determinants of health, as we know that health exists more than just inside of the four walls of any healthcare facility. And so the comprehensiveness of this report and addressing those issues was really wonderful. And I don't know that there's any particular point that I wanted to touch on specifically, because I think so many of them were so crucial into family medicine and caring for our patients. I do appreciate that this was very patient focused, and coming from a family medicine perspective, that's what we do this job for, is to focus on our patients and to provide health to the communities, and to improve the health of our nation. And one of the things, though, I guess in particular that I did like was the investment in primary care and the expansion of the primary care workforce, which is crucial to not only the health of patients, but if we do encounter worsening of COVID-19 or another pandemic in the future, this will be vital to ensuring the health of our patients in our country. And I do appreciate that telehealth was mentioned. I look forward to talking about that later, because as we've seen during COVID-19, there has been a quick adjustment in providing care and still being there for our patients, because even though the pandemic and COVID-19 has really taken center stage here, we've never stopped providing care in terms of chronic conditions such as congestive heart failure, diabetes, providing vaccinations. Primary care still continued forward, and I think that's something that we need to remember when looking at primary care as a whole. And then looking at primary care during a pandemic, I also want to recognize that family medicine physicians stepped up and really served in places that were not just in the ambulatory setting, but in the emergency departments, in the ICUs, in the hospitals itself. So investing in primary care as a whole will really invest in all of healthcare and the health of really everybody who lives here. So I look forward to our conversation. Thank you.
Terrific. Thanks so much, Kelly. Again, more food for thought. One of the things I can't help but raise, and this will come as no surprise to folks that know me, is as we look forward in terms of the delivery system and in terms of care in a new world order, in a sense, and that is the role of a variety of providers. The family practitioner is certainly critical in that context, but the role that nurse practitioners have played and the importance of those teams in terms of delivery, that we're no longer in a one-on, but rather how does one build a team and what is that team made up of? And the point that was raised about community health workers are a relatively new element of the team, and how we think about that and how we think about reimbursement systems. One of the things I'll want to touch on, if we can, and perhaps at some point go to Ben and talk about the role of value-based payment, how we are moving, or are we moving from essentially the fee-for-service model to capitated models, and whether that facilitates this new delivery system as we look about it. So let me begin, if I might, by turning first to Amy in terms of a couple of the points that she raised, and ask her to perhaps talk a little more in a little more detail. The point you raised early on was the question of the role of the federal government and how the federal government can help facilitate the kinds of changes that need to be made. If you think about it, are there states that stand out for you that have been unique in taking the opportunities made available to them in providing comprehensive primary care? And if you had your wish list, what is it that you would want the feds to do? what are the most critical elements near term as well as long term, because some of these things will take some time. So who's doing it well? Who's been unique in sort of taking the opportunities, and then what is it that the Fed should do, and where should we place those priorities? If I can turn to you, Hammy, and then I'm certainly encouraged both Ben and Kelly to comment on that as well.
Great. Well, first of all, my remarks are what I think personally, and so this is not a statement from the National Governors Association, where we have a very particular process about what we recommend from the federal government. So I will just say that. Just based on my work with states, one state, Rhode Island is obviously one, but another one is Vermont. If you think about what Vermont has accomplished, and they got their multi-payer advanced primary care practice demonstration approved. And through that, they have done some amazing work. They have been able to set up over 79 practice sites, serving 360,000. These are numbers that might need some updating, but this is what I have, which is more than half the state population. And, years ago, they expanded it statewide. And so they really took an opportunity that the federal government provided to them through Medicare and really expanded it to all payer and to really embed it in how their primary care system works in Vermont. So I think they're a great model when you really think about what sort of federal partnership can do to really catalyze activity in a state. It's interesting. And the reason I'm really focusing, again, from my sort of personal view on why federal investment is needed is because, the shortfalls that the states are facing are severe. I mean, they are really going to be very difficult over the next 18 months, 2 years. And so for things to move, there's going to need to be other support. And all of these initiatives, and Ben can talk about this from personal experience, it takes years, it takes time, it takes staff. I wish I could wave a magic wand and say, okay, let's set up all these systems and, in 30 days, we're going to be ready to go. It doesn't work that way. And so, the federal government setting the pace and the initiative and the options for states with some support, I think is going to be really critical for states to kind of move in that direction.
Ben, did you want to comment on that as well?
Sure, I'd be happy to. The other state that I would, certainly that we look to in Rhode Island, in addition to Vermont, which I mentioned, is more on the social determinants of health side, but obviously North Carolina is in the vanguard of how they are approaching that, and we're all trying to see, I think, how we can piggyback off that. But it underscores, I'd underscore the point that Henry just made on options for states, and then added another one. The federal government sort of having a role of collecting and coalescing around what works, and then knowing what will be sort of on a fast track and what might take sort of more time, provides significant implementation support to the states, I think, beyond what folks might consider, particularly in a reduced budget environment with stretched policy analysts and financial analysts and the like. And to give credit where credit is due, I think CMS has done an excellent job of modeling that during the public health emergency for the most part. What certainly would hope that comes with, and what I think the experience has been in Rhode Island to promote patient-centered primary care is one, being able to look across the HHS building at Medicare and see where Medicare and Medicaid can play a role together, particularly on value-based payment. Our experience in Rhode Island has been multi-payer, more on the commercial side, but that has been critical to our work in getting practices to buy in and having the appropriate funding sustainability. But lastly, we've had to find a way to support the infrastructure that it takes to build these practices, and the infrastructure that it takes to continue these practices and move the practices into more of a accountable care framework or some other value-based arrangement. All of this takes infrastructure, both physical and mental, in the form of technical assistance and other expertise, and that has to be funded. And it's not sort of funded through a reimbursable service; it's funded through a variety of different mechanisms. But having that kind of a funding mechanism, whether it's through a CMMI style structure, whether it's through in Rhode Island, we have a DSHB that we call our Health System Transformation Project that is taking a lot of this on. Those kind of funding arrangements are critical to provide the upfront capital for practices, for managed care organizations, for accountable care entities to invest into over the long term and be able to make that work.
Ben, I'm going to ask you to build on that just a bit. One of the interesting questions in terms of Rhode Island is you've got 3 health home state plan amendments in place, and you use patient-centered medical homes to provide essentially comprehensive primary care. What are the strengths of those models, and what particular challenges, barriers have you faced in trying to set them up, in addition to the cost of the essentially the setup? And I must also take the opportunity to note that one of the current projects taking place at the Bipartisan Policy Center is our examination of the coordination between Medicare and Medicaid, particularly for those who are dually eligible. And so this is a current focus. You know, Catherine might want to comment on it briefly in a few moments, but you're absolutely right. This question of how the programs coordinate, how they model one another, and how we benefit, particularly those who are, you know, that 9 million people that are essentially dually eligible for both programs. But Ben, talk for just a moment about Rhode Island's experience with those models and the waivers that you've sought, if you would.
Sure. So as I said, I think in my introduction, you know, our work on person-centered medical homes goes back into 2008, and the themes I'll sort of keep coming back to, and what I think has worked well in Rhode Island really is this combination of implementation support and infrastructure and multi-payer models. So right from the beginning, in 2008, this was a partnership between Medicaid and our Office of Health Insurance Commissioner, OHIC, to engage in primary care transformation over the long haul, and quite frankly, mutually funding that journey, or in OHIC's case, prompting and regulating commercial insurers in the state to do the same. And we've continued to add to that. So in particular, in 2012, we added the Integrated Health Home Program for behavioral health. And then in 2013, we expanded into a PCMH kids model. But throughout that, we kind of kept with the same infrastructure. And in particular, that infrastructure meant technical assistance in convening groups, in particular, an organization called the Care Transformation Collaborative. They have been integral to the success, and the funding of that, both from Medicaid and from the commercial side, has been integral to that success. And what the Care Transformation Collaborative, or CTC, does is they brought practices through this model, excuse me, and in a cohort manner, and provide that technical assistance and provide that training to do so. And then as we add in integrated health homes on behavioral health or PCMH kids, we continually sort of rely on them to teach practices on how to best operate in the model. It's not a light switch. As I said, it started in 2008 and now it's 2020. I think you can see, though, when we look at sort of as we're responding to COVID, just how valuable that model has been, both for PCMH and PCMH kids, as well as having an infrastructure like CTC available. So 70% of our primary care practices sort of over that time are in the PCMH model. So when we're thinking about how to respond to COVID, be that trying to catch up this summer on childhood immunizations after some absolutely staggering drops in the spring as individuals are correctly, physically distancing as they were instructed to do. We know who to call. We call CTC and we call the pediatricians who have been involved in PCMH kids for years, and help them do the work. They want to be involved because it's their patients, it's their child well visit, it's their relationship with the family that's been interrupted. And while certainly as pediatricians, they don't want to see, a measles outbreak, they particularly don't want to lose the coordination with the patient. And you can apply the same thing on the adult side, but obviously everybody's talking about the drop in ED usage in the spring. whether or not that represents missed care, whether or not that care has happened elsewhere, but understanding what's happening in chronic care and chronic care conditions and the connection to the medical home is additionally something that we are going to rely on this model that's been built up over time to promote. So again, like the reliance on that infrastructure and the collaboration that requires is tremendous, and it's not something that you can build over time. It's something that has to be funded, but it has to be again nurtured not just when you have a crisis like COVID, but well before.
A couple of things that I want to build on when we have a moment, and that is you briefly referenced behavioral. And of course, one of the challenges we know that exist, and again, another area that BPCs focus on is the integration of behavioral health into health services, and coordinating the primary care and integrating behavioral health in terms of the examination and the challenges that are faced, and coordinating between those providers. So we may, in fact, want to come back to that. I wonder, enormously helpful. I wonder, Kelly, if you might comment in terms of being on the ground and in these settings, in terms of the issues that Ben's raised, which is the continuation of relationships with patients, monitoring through that entire process. And really the reports that COVID has had a disproportionate impact on communities of color, and what you've seen in terms of the coordination with primary care providers, essentially how you're managing that population, what opportunities there are, and how it's playing out on the ground.
Yes, thank you. I think Ben made some really great points, and things that, as you were speaking, I reflected back to my time in the office and things I've experienced as a physician. We greatly saw the decrease in vaccination rates, even though we started a special time of day just for pregnant women and for children to be kind of a safe, or I guess more appearing safe clinic, because people were nervous to go out, and they were being told to stay home and to socially distance. So, that was one way in which we tried to keep our vaccination rates. And in the same vein, we utilized telemedicine for a lot of this. We would do the majority of our visit for well child visits in the morning via telehealth, and have them just come in to a nurse visit to get their vaccination and leave. And do their vitals and weight and all of those things as well. And so that greatly improved, our ability to be able to maintain our relationship with our patients, which in primary care is one of the biggest parts of healthcare and of providing care, is truly knowing your patients, what they're facing, and how you as a physician or a provider can help them. So thank you for bringing that up. In terms of, the populations you mentioned, there's always been disproportionate care in healthcare at baseline, and that's been significantly shown during COVID-19 due to the systemic marginalizations and injustices that really enact barriers to our patients receiving the care that they deserve. So when this happened, we saw just how egregious the marginalization in medical care truly was and is, because these populations are more greatly affected. So I saw in my particular patient population, a majority of my patients are Medicaid patients, recipients. A lot of them have jobs where they're not able to socially distance, and they have to go. They're essential workers. They work in environmental services, or they're public transportation workers. So they're consistently coming into contact with more and more people than what is being recommended, but they can't just not show up to work because that's their livelihood at home. Right. So that puts them at greater risk because they don't have the option to take sick days. At least a lot of my patients didn't have the options to take sick days, or to just not show up, or say that they were nervous about their health and the exposures. Many of my patients as well are patients experiencing homelessness, and that was another challenge, especially during the spike of COVID-19 here. We saw some shelters were not taking people from other counties if they were coming from across county lines to help to reduce transmission. And, from the physician standpoint, there wasn't much that I could do except for work with our community health workers to find other resources for patients. But even then, when they got into a shelter, that is a very challenging situation to be able to socially distance or to self-isolate if need be. And not to say that there aren't shelters that can't do that and don't do that successfully, but you'll find a variation of ways in which patients can maintain their health within those situations. And then in that same, that same token, my patients who are those essential workers coming home to their home that's a multi-generational home. And then how do you keep those folks within that same home space safe from you who's been out all day and interacting with people? So, I think a lot of these things we're seeing more so in these populations, in my patient population in particular, just because of the pre-existing marginalization and injustices that are outside of healthcare in particular. One other point that I wanted to make was at the very onset of COVID-19, we saw testing sites pop up that were drive-through only and in white affluent neighborhoods. And my patients, who I recommended testing to, I remember the first time I was sitting in our COVID call center and I talked to one of my patients who I quite frankly thought had COVID-19 and I wanted her to get tested. She declined because she did not have a car. She had to take 2 buses to get to the site. She didn't want to expose other people, and there wasn't an option for her to walk up to get testing. So when we talk about self-isolation and contact tracing and testing being a key to prevention and preventing spread, that's something that we really need to work on. And that's definitely a way in which this population was greatly more affected and disproportionately cared for during COVID-19.
Kelly, you raise an interesting question, and I'm interested in your thoughts as well as Ben's thoughts. And that is, to what extent do the Medicaid programs, Ben, in the context of the work that you're doing, Kelly, in the context of the providers, to what extent do they see an increasing role in connecting beneficiaries to services that are not necessarily health services as we traditionally think of them, but rather the broad range of social services that come into question in these circumstances, whether it's nutrition, whether it's housing, whether it's transportation? To what extent over time, Ben, let me begin with you, does the Medicaid program begin to look at, Medicaid is much better than Medicare in terms of the flexibility in financing, but to what extent do they begin to step up or see as an increasing responsibility creating those linkages? And then what does that place on the provider as a burden? We had a student at Harvard some years ago, Rebecca Oni, who ended up setting up a program for students at the time to work in hospital outpatient departments to essentially take orders from the physicians to essentially connect patients to primary care services. This has grown into an extraordinary business. She got a MacArthur. She's a remarkable person, but it's the fundamental question of, when do we begin to think outside of the box? When do we begin to see that as part of the responsibility? But Ben, how does that play in terms of Medicaid and Medicaid's responsibility? Hammy, interested as well in what you're hearing from the governors and Kelly in terms of providers. Where does that play a part in this primary care environment?
Sure, we're certainly trying to throw ourselves headlong down the path of addressing social determinants and thinking about upstream kind of concerns, and as Kelly and others mentioned of health equity. I think that the short answer to your question on whether Medicaid has a role in connecting beneficiaries to services is yes. The question is, and I don't think we're all in this experimental phase on how do we do it. And you touched on kind of, I think, the main concern that we get the most from, I think, very well-meaning providers, which is that MDs they're not social workers. And I agree. A medical doctor or even the RN isn't a social worker, but they shouldn't have to be the social worker. If we're thinking about comprehensive primary care as a place in which people go to get taken care of, and that is an entry point into the system, to me, that's how we can think about it. And that it's not that the physician or the nurse or the practice has the responsibility of addressing every social need, but that can be an entree into a broader system that has to be staffed by case managers and community health workers and peer supports, which I know are mentioned in the BPC report as being highly promising. And again, just to bring it back to sort of core theme, that is, that has to be sustainable. But so on the Medicaid side, I mean, we look from, what we can cover, all the way to how we can look at this from value-based payments. So on simply what we can cover, when we were putting together, and Governor Raimondo was putting together her FY 2021 budget, so the one that we're working on passing now, she said, I want to do something on social determinants of health and Medicaid. What can I do? And we looked at our data and said in 2018, Medicaid costs for 3,000 members who experienced homelessness exceeded $55 million. And on a per member basis, that's $10,000 higher than the general population. So the need is clear. And now homelessness and housing in general is a massive sort of problem. So what can we do on the Medicaid side? Well, we can look at waiver authority to cover home stabilization services. Now in COVID, we have emergency authority for emergency case management for those experiencing homelessness. That is, I think, the bare bones of what we can do in Medicaid and in partnership with CMS. But our hope is that it has to be, part of a broader conversation about housing or transportation or food insecurity or economic insecurity or police brutality or all of the upstream determinants of health. The other thing that we hear in these conversations, I think we have to be sympathetic to and understand that this is a societal response to social determinants is, let's not build a bridge to nowhere, by which, folks in the provider community, I think reasonably mean, you can give me an e-referral system to connect someone to, housing support services. But if there's no house for them to go to, or there's no supportive care for them to go to in the home, it's not really going to do anything. And looking at that systemic response is tremendously helpful. So I could absolutely kind of, keep talking. I think the other, piece I would mention is, to me, this is the tie into social determinants and value-based payments become sort of very clear. If we give more flexibility on either a capitated model or integrating social risk scores into rate setting, or providing kind of practices or managed care organizations greater flexibility in what they can spend on to impact social determinants that they think will drive, ultimately the cost of healthcare down. That's what we hope to get by value-based payments. That needs to be proven out over time. But I see these conversations as linked. And I'll close with the example I always sort of use that I think sort of crystallized in my, staff cringes because they've heard it so many times is, we talk a lot about, how do we avoid ED utilization, and shouldn't we be able to control sort of asthma better or other kind of respiratory problems? Like, well, when in my household, when we, we're starting having sort of more seasonal allergies, we just bought an air filter. You can't do that for Medicaid beneficiaries unless you have, waiver for this or waiver for that. But in a value-based payment methodology, don't we want the doctor not to just write a prescription for an inhaler, but write a prescription for an air purifier, or at the very least, kind of connect individuals to housing stabilization services or other kinds of services that can improve the quality of housing that has a direct effect on respiratory health, for example. So simple example, but one in which, I think kind of proves out or hopefully proves out what we're all trying to get to with the integration of value-based payments and social determinants.
Amy, did you want to comment?
Yeah, well, that was great, Ben. A couple of things to build off of. Really thinking about where states can invest in social determinants of health has been sort of a long-standing question that we've all been thinking about. I think it's just become more acute in the COVID context when we've seen the disparities and the need. I always think of two examples, and you already mentioned one. I mean, North Carolina certainly had some federal support to build out not just the referral system, but also money to invest in some of these other services that Medicaid wouldn't otherwise cover. I would say that the same is true in Oregon, where they built out the coordinated care organizations, and they've really built a system where they've had more flexibility for those CCOs to invest in these types of interventions, which I think they have seen an uptick in health outcomes. One thing I think that's continually challenging on the Medicaid managed care front is how are they able to continue to invest in non-medical services? And and have that work in their business model, you know, with their medical loss ratio. And that piece, we have been thinking about that for years. I know other people have been thinking about that for years, and I don't want to derail the conversation, but I think that's one of the challenges. And I think the other piece is, where are there opportunities for additional federal dollars for those types of services? I don't think another state has gotten an approval of a waiver like North Carolina, even though there have been attempts to do that recently. So I think that's also a limiting factor at the moment. One thing, you know, you always like to say you don't like any good crisis to go wasted. So, you know, one of the things where there's really been a lot of focus on is contact tracing. I really appreciated Kelly mentioning that. There's funding for that. States are investing in that. We have to do a better job of that in order to get our arms around a pandemic as we continue to reopen across the country. And a piece of that is really making sure that the at-risk populations have the appropriate supports to do what they need to do to get tested, to isolate, and to quarantine. And I think that's an area where there needs to be more focus. And some of the states have started to do that. They've been thinking through, okay, how do we organize our efforts to really to address those populations, and how do we make sure that we're able to do what we need to do to give them the extra supports they need. I don't think anyone has solved it. I think, you know, we're flying the plane as we're building it, so to speak. But that is where we are focused on at NGA, is really trying to help states address that as they build out their contact tracing efforts. So I didn't want that point to get lost, because I feel like it's an opportunity.
Amy, it would be interesting, not today, but over the longer term, to understand how the states have used the money that have been provided to them through the CARES Act activities. You know, we hear anecdotally some states, you know, how they're, you know, either sending it to the communities or to counties or to cities or to particular projects. It will be interesting in retrospect to look back at how those funds were used and what we learned from that in terms of opportunities. And, you know, to what extent it enhanced this primary care, you know, full service kind of set of circumstances, I think will be quite useful. Kelly, any additional point you wanted to make? And then I'd like to turn to the question of telehealth and other new models and the impact that's likely to have on primary care. But anything else, Kelly, in terms of the social determinants you raised? I think a very important question. And I think both Ben and Amy's points have been quite helpful.
Yeah, I absolutely agree. I think that primary care very much fills the role that we're all speaking to now, and we just need more to help us do that, because it's been mentioned, you know, a lot of providers say that we are not social workers, and I think it's because we can't live up to the expectations of social workers because they're so incredible. We just need to know what resources even are in our communities. I think that would be a good step as well. So I often utilize a tool that the AAFP has called the Neighborhood Navigator through the Everyone Project, which focuses, you can look up your zip code and see what resources are around. And that's, you know, one step for a physician, especially if you're or a provider who's new to an area and doesn't really know what's around, and you don't have a case manager or a community health worker. I mean, that's a good start. We're not social workers, but I think it's our role to do that and to provide that care for our patients.
Terrific. I want to touch on the sort of telehealth issue and how that is altering how we think about care, and whether the sort of resurgence or the growth and interest will be maintained over time. And then we've gotten some terrific questions from our participants that I want to turn to as well. So let me, before I turn to those questions, just raise the issue of the unique increase in use of telehealth, the waiver authority that the department has essentially allowed, issues of origination. I mean, a whole set of questions around the use of telehealth on the Medicare side, which has radically increased utilization. Is that going to continue? To what extent is that an important role for primary care, or a tool for primary care going forward? The question of whether or not these waivers are made permanent, the questions of what the states have done individually in terms of Medicaid. So just a quick response from each of you in terms of what we might imagine. Let me begin with you, Kelly.
Thank you. I think that it is going to be necessary to continue telehealth provision. We've seen a great increase in the amount of patients who have come to the physician, who haven't been there otherwise because of whatever their barrier might be. I think it's really improved a lot of patients showing up. Granted, there are barriers to even that with technology and assuming that people have access to a telephone or to internet. So those will be challenges as well. I don't think we will ever see the in-person patient visit go away, but I think that this is a time when we need to continue to have telehealth medicine. I think Ben spoke to earlier about the decreases in ED utilization in the spring. And I will say, I cared for several patients acutely through video visits who otherwise would probably have gone to the emergency room if they didn't have contact with a physician to make sure that they were okay. And so I think that greatly aids in decreasing that high utilization as well. And so I'm hopeful that it'll continue. And this is just one way to improve access to care for our patients.
Okay, Ben, how's Rhode Island looking at this?
We're very much saying we want to make sure that people have access to care now, which means telehealth, and have been aggressive and in some cases lucky. And lucky because I say we already had telehealth in our state plan. We didn't have to do anything fancy. We just had to operationalize it, and that was maybe the first 2 or 3 weeks of COVID response for a good chunk of the team was just opening up telehealth codes. But I think where we are now is to get at some of what Kelly was saying. We hear the anecdotal evidence, and we hear the anecdotal evidence from providers and patients who seem to really like telehealth and want to keep using it. And you start to hear some of the trepidation on the payer side about potential misuse, about clinical appropriateness of certain telehealth services. And at the risk of being wishy-washy, it's just too early to tell. And I think that'll be a national conversation. I think we want to set up, at least in Rhode Island, as much as we can and think about this as an experimental period. It seems highly likely to me that there'll be opportunities for ED diversion or other chronic care management using telehealth. And it also seems likely that there'll be places where you will want to see an individual in person. That we're going to have to rely on clinical experts and the data to tell us where. The last thing, so I mentioned in terms of real promising outcomes that we're seeing really across the board, providers, patients, payers, is just how valuable telehealth and even audio only telehealth has been in the behavioral health space. And Kelly spoke about reaching out to different kinds of patients. At least anecdotally, but also starting to see in some of the billing data, that has been a real benefit to behavioral health and behavioral health integration and behavioral health services, which are a huge need in normal times and obviously a growing need during this public health emergency.
Good. Amy, any final comment, and then I'll turn to our external questions.
Yeah, the only thing I would add is, it's interesting on the telehealth front for behavioral health, we're actually doing a particular project around that and how to help states really focus on, really supporting the behavioral health systems, especially during this COVID crisis. And we have gotten some intel that some behavioral health providers have found this challenging. So there are some providers where telehealth has been something they've been able to go to, they've been able to sustain operations because of that. And others have said, especially for substance use disorder, they have found it somewhat challenging to not have that, face-to-face interaction, and they haven't been able to really pivot the way they would have liked to. So there's a little bit of a mixed message there. I think the other piece of, are we going to really look at this long term? I mean, look, we've made more progress on telehealth in the past 3 months than we had in 5 years. I mean, that's the reality across payers. Mm-hmm. But we are certainly, as been noted, hearing from the payers in particular about concerns around oversight. And I think there's a real interest in, after the emergency, are states going to have enough oversight structure to really make sure that, the right services are being delivered. So I think, the jury's still out. I think, we're really going to have to see how folks are able to work within this new system that we all are living in. The other piece I would say, and Kelly, you mentioned this earlier, childhood immunizations and child well checks, the child abuse reports our way down. I mean, all of these touch points that are needed need to be brought back, because that's a huge missing element. You know, and we're doing some work at NGA on sort of vaccinations and how to make sure that there's going to be, both for flu and for childhood immunizations, how we're going to be able to, and COVID, frankly, one day, how we're going to be able to get that back into the mix. So I just mentioned, you know, I think all good things, this is going to have to kind of fit into what we need to do when we get everyone back into the offices.
All right, we're going to go to a lightning round. And with as many of the very thoughtful questions that we've received as we can. Let me begin. Let's see. Let me begin with actually one that we haven't talked about at all. And that is how the states are addressing primary care workforce shortages, which we know exist for a host of reasons. And the individual added to that is integrated clinical pharmacy being utilized as part of the primary care delivery system for people with chronic conditions. So who wants to quickly address the primary care workforce shortage and the use of clinical pharmacy? Ben, you're up.
All right, I'll at least take the first part because it's easy for Medicaid directors to just ask for more money from the feds. So I'll do it again, which is that, you know, what we hear from, you know, our primary care community in Rhode Island is that, you know, that moving Medicaid rates back up to Medicare rates and the 100% FMAP funding to do so would be a game changer. That, you know, primary care physicians are already you know, paid less compared to more specialist counterparts. And that's, you know, that increasing reimbursement is a critical but simple part of it. And that's, you know, the broader kind of issues around primary care wages versus specialists is, you know, a whole different conversation. But I think that recommendation from the BPC report, you know, speaks volumes.
Okay. Let me link to that a question specifically to community health workers. And the question that was asked was whether community health workers add value. Kelly, over to you. You seem to be quite committed to the use of community health workers. And do you want to comment briefly on the value proposition of community health workers?
Oh, absolutely. Even in my own personal practice, I'm fortunate enough to have a case manager and a social worker, but that is only 2 people for a large practice of resident physicians. So still severely understaffed, but when we are able to utilize community health workers to their full potential, and not overburden them too much, we see great outcomes with our patients, and they make such great relationships, just like the providers do with the patients as well. And they become another person that they trust within the office and who can genuinely help them, and can also help whoever the provider is addressing needs that maybe we didn't touch upon in their appointment time, or something that we potentially didn't hear or overlooked. So it is really a valuable teamwork effort to have them a part of the team.
Okay. Let me add to this question of sort of non-traditional services, a question about whether or not medical nutrition therapy is one of the services that you're looking at in the context of broader social determinants and contributors to those issues, and whether they are among the services being considered for Medicaid workers. Let me talk to Hammy and then Ben. Either of you comments on medical nutrition therapy.
Medical nutrition therapy. So, you know, we are hearing from our state leaders that food insecurity is becoming, it already was a challenge, is now even more so in the context of COVID-19. In terms of whether Medicaid is going to pay for medical nutrition services is not a question that has come to us at NGA. I think it's, you know, how is the role of primary care, and how are we going to actually expand our, you know, our food services and our home delivery and those pieces to make sure, as part of social determinants, that people are getting what they need. But we, and Ben, you might have a different perspective, but we have not gotten the question of how does Medicaid pay for food services specifically.
Okay, Ben?
Yeah, we've gotten similar to having more around, particularly in COVID, sort of meal delivery. But I will say, just, and this is not based on a particular knowledge in Rhode Island, just sort of previous work in Massachusetts, that many providers and integrated providers are leading the way on this. So I know Boston Medical Center has a really interesting nutrition sort of food program, and Healthy Garden and things of that nature. So it's not something we've looked at specifically, but it's something that we'd be certainly open to.
Okay. An interesting question that touches on all of these things, and that is, who should coordinate the delivery of essentially non-traditional services, community-based services, whether it's any kind of a non-medical service? Who should coordinate that? Should that be done by the primary care provider? Should it be done by the community health center? What are folks' experience with that? Kelly, Ben, either of you?
Yeah. That's an opinion.
I honestly think whatever is the medical home and that main first touch point for a patient is going to be the appropriate place. And that's not to say that they don't need resources or support from outside factors. But I do think that first point of contact and where they come to most frequently and where they most trust is going to be the good point for them.
Okay. Ben, you've been asked to sort of elaborate for a moment on how to use value-based payment to address the social determinants,
Sure.
some of the issues we've talked on.
Yeah, I think and I think it relates to the previous question as well. So one sort of really, maybe overly crass way of looking at it is that the people who are going to eventually be able to have the sustainability of funding to coordinate care and to coordinate social needs are the ones who should be responsible. I think in Rhode Island, our feeling on that is that that should be our accountable entities, which are our accountable care organization model. That model needs to promote and invest in community-based organizations that understand the needs of their community, and in particular are place-based and properly understand sort of their role. So we see, at least in Rhode Island, kind of the confluence of accountable entities that are more at risk and therefore for payments, and therefore have the incentive to do so, combined with community-based organizations, and in particular investments that in Rhode Island has made, and particularly through our Department of Health, what we call health equity zones, as being a place where those connections can be made between practices and the community, as being kind of that next layer of coordination and integration. For my predecessor, something that kind of stuck with me for Medicaid, which is like our core is to set policy and to pay for things. So I can set policy around what we can cover, and then make sure that we're continuing to cover it. But I certainly think sort of Medicaid agencies needing to provide that sustainable funding and that impetus for greater partnership between accountable entities and community-based organizations, is the vanguard there, because that's who's going to have the vested interest in addressing those social needs that we know come down and show up in our healthcare system. We're paying for it on the healthcare side. We should pay for it more upfront with other investments in social needs, but certainly using the healthcare system where we can.
So yeah, go ahead, Amy.
Yeah, I just wanted to, I thought that was great. And one thing that I'm really interested in seeing is there going to be more interest from the provider perspective of these types of arrangements? Because I think COVID has really shown a light on, when you rely on utilization, kind of the perils of that. So, we at NGA are really thinking about this very carefully about, what are going to be kind of the provider interest and support for some of these payment models that we've been working on for a while that don't always have the provider support, frankly, and what models are going to allow them to, because they're also, some of them are in, have some concerns around their operations. Mm-hmm. What models can support them during this difficult time, but then also lead to the longer term, move from volume-based to really capitated or, some other sort of value-based proposition. So just want to make that comment.
Well, and one of the questions that has been posed as we move to value-based payment, whatever form it takes, what's the control on quality?
Yeah.
And to the extent you move away from the sort of traditional, not that fee-for-service necessarily brings with it the best quality check, but the question is, when you move to those models, what's the tool to be used to assure that the quality of care being provided? Thoughts on that?
I'm happy to start. I mean,
Yeah.
at least in the Medicaid AE program, we have the specific quality measures that are in the contract. Our AEs work as contracts with our managed care organizations, but they're very similar to the contractual quality requirements that we have with our managed care organizations. So that has to be a fundamental baseline. I think in it, the other sort of interesting question is how do we push beyond those kind of annual measures to make sure that we have some more leading indicators of progress. That could be social determinant screen or child well visits on a less lag basis. Those kinds of things that we're particularly concerned about. And then just to sort of add, to Hemi, your point. I mean, nothing has shown for us, the downsides of a utilization fee-for-service based system than massive exogenous shocks to utilization that nobody prepared for. That has, and the amount of time, it was referenced early on, that certainly my agency, and I'm sure many others and across Rhode Island and state governments, are being spent trying to figure out provider financing through CARES Act and other relief. Capitated models, wouldn't necessarily be the be all end all of that, but would certainly help and I think promote that creativity and investment. So we are seeing providers have much more interest in capitated models than we did previously, kind of recognizing the limits of the fee-for-service system to their business model in the midst of a public health emergency.
So two last very quick questions in my very almost no time. One was a comment made that COVID-19 has exposed the fragility of reimbursement, reduced hours, no resources for virtual care, et cetera. Should we guarantee essential services in fee-for-service markets, such as primary care services, the integration, and so forth? Should we guarantee that as part of the fee-for-service side of this, assuming it will stay in place? And then let me list the last question, and you can choose from among you as who would like to answer it. Wouldn't Medicare be all much simpler? Why not Medicare for all? So who would like to take on either of those questions?
I'm happy to take the first one.
Okay. All right. Go with the Medicare for all.
No. On the first one, so I mean, I think there has to be recognition that we need to continue to invest in the structures that we have in place. So there's a lot of fee-for-service arrangements out there, and you're not going to be able to flip a switch and all of a sudden say, okay, everyone's on VBP, here are your targets, next month, here we go. So I think it's, there's required investment in some of the models that we currently have, and slow movement, allowing people to get to that next place that we all think could have a lot of potential. So, yes, I think immediately we are going to have to invest in some fee-for-service models and help, providers get over their, 3 months of lost revenue, right? 4 months of lost revenue, 5 months of decreased utilization. It's going to be, I think, of critical importance, because we need to have those providers to make sure we have access for folks. So that's my personal view.
Okay. Last question, Medicare for all. Would anyone, either Kelly or Ben, since Amy's avoided it completely, do either of you want to comment on that? Okay. On that basis, I'm going to turn this back over to Catherine Hayes and thank all of you for just a terrific conversation and a great amount of insight. So thank you for that. Catherine, over to you.
Yes, thank you all for participating in the panel. I'd like to thank the Commonwealth Fund for their support of this project. And I would be remiss in not mentioning Kevin Wu and Eleni Salyers for their contributions to this project. So thank you all very much. Take care.
All right.